The study is about testing the non-inferiority of low-dose olanzapine tablet versus the standard dose olanzapine when it is given with highly emetogenic chemotherapy along with triple anti-emetic therapy, inclusive of single dose of steroids. So it is essentially testing whether we can achieve the similar kind of anti-emetic control with 2.5 milligram low dose olanzapine versus standard dose, and with a favorable toxicity profile, especially related to daytime somnolence, which is the most dreaded complication with standard dose olanzapine. So this is essentially a phase 3 randomized open label 2-arm study wherein 2.5 milligram versus 10 milligram olanzapine alongside triple antiemetic regimen is tested in 1:1 fashion. The randomized registration is central, so there is it is concealed about which patient is going into which arm. It is open label, and with open label there is always some problems of assessment bias. So for for minimizing those, we tried to make the outcome assessors, which are the study staff who were collecting the daily diaries and asking patients on daily basis about the symptoms. We masked them about the allocation of the arms. The primary objective, as I told, is to test the anti-emetic control between the two arms, and we define the primary endpoint as complete control, which is no nausea, which is no or minimal nausea, no vomiting, and no use of rescue medication between the two arms. And we found this complete control is equivalent in both the arms, 44% versus 43.7%, and it is not so the test arm was found non-inferior to the standard arm. So I think very relevant question, and I would like to say that this was a very relevant question globally, because we know that the nausea and vomiting is a dreaded complication with highly emetogenic chemotherapy in cancer. And many times patient they are afraid of taking chemotherapy at time. They want to skip, they want to become non-compliant due to this kind of side effect, and it's a very bad feeling of being sick and not able to do the normal activities due to this kind of feeling. So there are attempts to improve the nausea vomiting control, and while the standard 10 milligram dose of olanzapine is very effective in controlling nausea and vomiting along with triple antiemetic regimen, but it is associated with very high daytime somnolence. There was another attempt to reduce the dose to 5 milligram, but again, that dose was also found to be very highly associated with daytime somnolence. So this daytime excessive sleepiness can affect the daily life activities and make patients, not able to take interest in any other activity, which is again a very dreaded complication. So we attempted this study with a very low practical dose, first of its kind, and 2.5 milligram dose in clinics. Off and on, people try, and they found that this is also effective, but there was no randomized evidence for that. So we used this dose, and we found that not only this dose is non-inferior to the standard 10 milligram dose in controlling nausea and vomiting, but also it was associated with significant lower daytime somnolence, which was our secondary endpoint. So this is very, very impactful. This is very important, interpretations, and it is having widely practice-changing implications, because now we have an evidence in randomized fashion that this low practical dose of olanzapine 2.5 milligram can be used widely with highly emetogenic chemotherapy, especially with cyclophosphamide anthracycline based, which is the predominant population. And it is not only found inferior, but it is also associated with much less daytime somnolence for all grades in all days, as well as severe grades, which was most commonly found in day 1. So again, very relevant. So we tried to use a triple antiemetic regimen along with a single dose of steroid rather than the delayed steroid accompaniment, because steroid is another important concern when we use a highly emetogenic chemotherapy and we give delayed steroid. The steroid itself causes a lot of side effects. So although in this study we use single dose steroid along with a low dose versus standard dose olanzapine. This was not the major study question. So we would like to do another trial with, a low dose versus standard dose steroid along with this low dose olanzapine to see if when we are using standard steroid, when we can further increase the efficacy of low dose olanzapine, and whether if we decrease the steroid, we can really decrease the steroid related side effects, which is at times very, very relevant, especially for the population where an steroid restriction is mandatory, like diabetics, and some other illnesses wherein we required steroid restriction. I think, since this is a very low practical dose and this can actually benefit masses of patients globally, and, this intervention is not even costly, I think this should be adopted as a standard of care globally, as fast as possible. And I believe that guidelines should adopt this kind of dose in their, as one of the standard of care.